All right, we got a good case here that I want to talk about on patients that have already developed severe degeneration of the articular cartilage. Typically, we know that in this type of patients that have no cartilage left either in the medial or the lateral compartment, they tend to those patients tend to be a little bit more difficult to treat, especially with biological treatments like PRP or stem cells. Especially in the younger population, the active population, the ones that we typically describe as in the treatment gap. We've done some videos in the past talking about the treatment gap, but this particular patient, he's in his 40s and 50s. Unfortunately, when he was young, he played, was very active. He had a medial meniscal injury, and unfortunately, they took out almost the whole medial meniscus. Essentially, they meniscectomized him. That needed to be done because he had a big bucket handle meniscal tear at that time. But now, we fast forward 20 years down the line, he's still active, he still runs, he tries to be a triathlon, and now we have no longer meniscus, and beginning to notice that he has no longer cartilage. If we look at the outside, the lateral compartment, we have a nice lateral meniscus, and we have nice thick cartilage on the lateral compartment. If we look in here, essentially the meniscus is no longer there. Essentially, it's absent because yes, it was taken out a long time ago. When we look at the articular cartilage, he also has no articular cartilage left. The last thing that we're noticing is now we're developing bone edema. We call that essentially bone edema. Independent factor, which means that we know that there's a lot of nerve fibers around that bone edema, extremely painful. When we see bone edema on an MRI, we know that these edematous changes do not get better. On the contrary, if we repeat MRIs a year down the road, that is only going to stay the same or only get worse. We also know that when patients begin to have bone edema, their likelihood of requiring a total knee replacement is significantly higher as if he didn't have the bone edema. This is a patient that have already had done pretty much everything. He had steroid injections, hyaluronic acid, had PRP by another provider, and unfortunately he's still pretty limited. The knee does get swollen. He does not want to do a knee replacement because of his age and his activity. So what we decided to do is we decided to do an intraosseous injection. Why intraosseous? Because whenever we see this, we know that if we just inject PRP and growth factors inside the knee, a lot of the time that does not really penetrate the intraosseous compartment, and there's still a big failure rate. So what we do now, this is the same patient. We could quantify and measure exactly where that edematous compartment within the bone is, and with a special technique, we do have to do a nerve block. We knock out the genicular nerves. We also do a Wallen technique, which we put a lot of lidocaine around the bone. We go inside the bone, right inside the area where the bone edema is, and we inject growth factors from the patient's own cells. That was done about 6 weeks ago. Now he comes in with his follow-up. It's about 70% better, able to do a lot of those activities he could not do before. And this is one of the new things that we're doing to try to treat patients with severe bone edema, essentially equivalent to bone-on-bone osteoarthritis, that are falling into the treatment gap. Because yes, a knee replacement will probably be the best thing for him for the pain in the long term, but he's too young and he doesn't want to do that at the moment. Doing this type of procedures might be able to buy him a little bit of time, so until he's ready for that knee replacement. Thank you.